is 15 minutes past the hour. Welcome back to Jeff Koinange live on the road. That's right, we are at the KEMSA RDC in Kisumu Town, Kisumu County. And our topic is KEMSA, the way forward. You know the reputation it's had the last few years. Is it time to turn the corner? Well, joining me is a very strong panel. Right next to me is the chairman of the board of KEMSA, Irungu Nyakera. He joins us live. Thank you, sir. Right next to him is the cabinet secretary for health, Nakhumicha Wafula. Did I say right? Nakhumicha. She's laughing. Right next to her is the chairman of the National Assembly Committee on Health, Dr. Robert Pukose. Right next to him is the man who runs the county of Kisumu, Professor Anyang' Nyong'o, the governor himself. And right next to him on the very far end, former governor of Uasin Gishu County, now the senator of Uasin Gishu and the chairman of the Senate Committee on Health, Jackson Mandigo. Please welcome all our guests on the stage, please. Ladies first.
Oh,
since you were laughing at me a moment ago, let me start with you. You had an event today with KEMSA, right?
Yes,
How'd it go? Tell us. And what was it about?
Thank you very much. Good evening, viewers, and good evening, the people of the great city of Kisumu. Today, we were here to launch our regional distribution center for KEMSA. The event went very well. And it is part of our journey of building back the public trust into the institution. So we are here to ensure that now the counties from this side, who are our major clients, can be served from nearby. Yeah. So we are now looking at how do we reduce the time between when they order and when we deliver the supplies. That's why we have brought services closer to the people. Yeah.
And Chairman, you heard what the CS said. For months or maybe years, the reputation of KEMSA was least desired. People didn't, when you mentioned KEMSA, people had a very wrong impression. Did you know that coming in 9 months ago into the job?
Yes, actually, I don't know if it was the wrong impression or it was the true impression of KEMSA, because I remember even when the president was appointing me as the chair, the thing he told me about is that we have to come and clean KEMSA. And of course, he threatened that he will, the same way he disbanded the other boards, is the same way he will disband ours. And I must say that over the last 9 months, when now we have been overseeing KEMSA, there are a number of things that we have. First thing is we came in and we learned the issues at KEMSA. The first was we looked at the culture change. There was a bad culture within the organization where people really, some people were working from home, about over 200 people, others were in the office. So really it was, there was no way that they could work together, and they never felt that they were part of the organization. And from there then we looked at the issues of governance. There was the role that the board was to play and the role that management had to play. The board could only play a very strong oversight function if actually we separate the role of the board and management. Then the third thing was issue of accountability. A lot of times when you look at, because we do not have the right systems, you don't even know who did what and when. So again, we started putting together the structures for accountability, and one of them that is currently ongoing is the ERP system that then we can even trace on who did what at what time. Someone,
Okay, hold that thought. We'll get to the systems in a moment. Professor, Governor, what does regional office for KEMSA mean for your county?
Well, the regional office is it's a regional office. It means that my county will get supplies from here rather than wait to get them from Nairobi. And I'm glad that they are introducing the ERP, that is Enterprise Resource Program. It's going to make it very easy for Susan to know that what leaves Nairobi for the Kisumu regional office actually arrives here. And that what leaves here to go to Kisii actually arrives in Kisii, using that ERP. I could say more because when I became Minister for Medical Services several years ago, I was in the same shoes like Susan. I found a KEMSA that was really, really bad. And if I was to tell you that story, we would spend the whole night telling it, so I'll leave it for today. But what they have done, cleaning up KEMSA that they have found rotting, and affecting these regional offices is going to be a major transformation, I think, in the distribution of pharmaceuticals and non-farms that are handled by KEMSA to the counties.
Dr. Pukose, speaking of the rot, you're oversighting. Part of your job is to oversight KEMSA, right? Yes. It's a difficult job with all the rot that's been there for so many years.
Thank you and good evening, viewers from the beautiful city of Kisumu, which I think is the cleanest city within within the country. I would say that, you know, you're saying KEMSA is rotten. It was true, it was rotten. And it is good that we are in a clean city like this, that we think of cleanliness in KEMSA. As a body that oversights KEMSA, we've given, you know, when we had a board that was disbanded, this board has been there for the last 9 months. We've given them time as a committee to be able to put their systems in place, to be able to, they ask for money, which the committee and parliament appropriated, 2 billion as a capitalization fee amount of money. And with that 2 billion, we expect that KEMSA will now be able to roll. 2, we were to have a meeting even with KEMSA beginning this week, but because of the event of today, we have given them 2 weeks to prepare, because we now want the chairman and the board and the management to be able to brief us. What is it that they have put in place to make sure that KEMSA now can be able to deliver and in a more transparent way, and make sure that the corruption that has been associated with KEMSA is completely eradicated. So we expect that they'll be able to give us that report, give us an update, then from there we can be able to move forward with KEMSA and make sure that it delivers on its mandate.
Sure. Senator Mandago, the reputation of KEMSA, you think they can shake off that old reputation moving forward?
Thank you very much, and good evening, viewers and people of Kisumu County. Yes, indeed, Jeff, they can shed off that perception. They are already working towards that. From the reforms KEMSA has initiated, we can see them actually achieving that success story of KEMSA being the premier pharmaceutical and non-pharmaceutical distributor in the country. I say that because, Jeff, for the last 9 months, we've engaged with KEMSA board and management as the Senate Health Committee, and part of the recommendations that we've made to them, and they have already implemented, Chief, was first stoppage of the hiring of private go-downs while there are existing government stores. And that is good progress because it enables them now to manage their products within their premises. Secondly, Jeff, KEMSA had a serious issue in terms of expiries of drugs. And the amount of drugs that were being destroyed on account of expiry was costing the government billions of money. We are happy that now KEMSA has reformed and put in place expiry date policy program to ensure that drugs that have short life shelf, are procured on a demand-driven basis to enable them to be able to distribute and cut down on losses on expiry of drugs.
Absolutely. Madam CS, you fired the entire board, the last one, right? you went and you fired everybody, and you hired Irungu and the rest of the team.
Yes.
So far, how would you rate them? Even though he's here with us, how would you rate them?
The chair and the board members, they know that I don't mince my words. When they're doing well, I say it. And they will tell you that last week I popped in the evening and we had quite an intense conversation on the progress that they have made so far. So since they came into office up to now, one is that we have managed to improve on the fill rate. Initially, counties would make orders to KEMSA, and they would only manage 30 to 40% of what they have ordered. That out of a total of 100 items, they would only fill 30 or 40 of them. Yet these are essential supplies. But as we speak today, that has now moved and we are headed to 70%. So if I was to rate and use that as a metric in terms of measurement, then that is a step in the right direction. The leap from 40 to 70%, that is in the positive direction. The other thing was that our turnaround time, KEMSA was taking too long to service orders. So now we needed to reduce that turnaround time, because the longer they take, it means there's a patient somewhere who is not able to get what they ought to be getting. And one of the strategies to reduce that turnaround time is having this regional distribution center. That the counties from this region, where ordinarily they were taking up to 22 days, 19 days, 15 days to supply an order. In my morning address, I said there's no reason why Kisumu County should not be served within the same day. There's no reason why Vihiga County, which is just across the river, shouldn't be served within 24 hours. So those two metrics, in terms of turnaround time, how long they take to process the order, and the fill rate, I will rate the board as having done very well. The other issue we had, the bigger issue, of course, is on staff and management. And the chair has already alluded to it, that by the time they were coming into office, we had a cohort of staff who are working from home since the COVID time, despite having overcome COVID, and now people are back to office to work physically. And the institution had hired another lot of people working from the office. They were meant to work for the same institution, so they couldn't work as a team. There was no collaboration, there was no teamwork, synergies were missing. So I remember the day I went to inaugurate the board, my first decision was to bring back everybody to the office, so that then people can now be put rightfully in their jobs, the skills they have, and work as a team to achieve the objectives. And I want to believe that the success that we have seen so far is attributable to that action that we took and the continued governance reforms that the institution has continued to put in place. And that is not to say that there are no issues. During the day, we experienced an order being processed for Vihiga County, that out of their total order of 20 million, we have only managed 16 million. That says there are some items that were not supplied. And when we looked, one of the items is a very essential antibiotic. So I was telling the board, then still there's something that we haven't gotten right. And that is why I want to agree with him and the other members, especially Governor, regarding the ERP system. That now we put in an information management system that then ensures that we do proper quantification. That as a national government, we know exactly what it is that is required. We practice proper inventory management to see the stock movement, so that by the point a county is ordering, our endeavor is to supply 100%. So there are still some little gaps here and there, which I believe with time they should be able to overcome. But they know if they don't do it, they know what will happen. So it's okay.
They know.
They know.
Chairman,
They know.
Chairman, is she tough?
Yes, certainly.
Look, you probably wouldn't be in office if it wasn't for that mosquito net story.
Yes, that's true.
For those who don't remember that story, explain it to us and the consequences that happened thereafter.
I think that essentially what happened is for the malaria nets, what's called the LLINs, and they were being procured by KEMSA, and there were issues of irregularity that were highlighted, and they were highlighted by Global Fund. And so with that is actually how this board came to be. Whereby the president, together with the minister, they disbanded the board and brought in the new team. And what I can say is, since we came on board, we've worked. We worked with Global Fund on what we could. The procurement was taken to the Global Fund head office, where it was still procured under WAMBO, the Global Fund procurement agency. And then the nets came to Kenya. They were stored and warehoused at KEMSA, and they are currently being distributed by KEMSA. So KEMSA has three functions. One is on the procurement, warehousing, and distribution. So the only function that then KEMSA did not get paid for is the procurement function. So KEMSA still gets paid about 8% of the total fee that they should have been paid 10% for.
So you didn't lose out too much?
Okay, not that too much. It's just that one is there's no money that left the organization and went out.
Right. But the 2%.
2% is fee that we would have earned, but we didn't. But the potential fee. But even more so, it's more around the image, the dented image of the organization. And that's why really, as I was saying, from when we came in, we knew that we are working from a place where there is no public trust. Our image is dented, and we have to do whatever it takes to ensure that we do not have anything close, anything around a scandal at KEMSA. And I would say 9 months later, we've succeeded in that.
Because she's watching, you know that.
She's watching.
Yes. Governor, the other thing that the CS said is that counties need to pay their debts, right? Pending debts, a totaling amount of 3.2 billion. Are you aware?
I'm aware, but you see, the reason why counties don't pay their debt or incur debt is as a result of the division of revenue. The thing is that the health is one of the most spent on function in the counties because health is very important. Next to it is education. These are two very fundamental functions and services that counties give, and they consume a lot of money. So if we do not get enough, we incur debt because you have to have money to buy services. You have to have money to buy drugs and so on. So if there's a shortage in the budget to the health ministry or health department, then of course you'll have to have drugs, even if you don't have the money, and that means debt. So we really have to be very careful at both my friend in the Senate and the Assembly, that since health is very important to the function of the county, it should be adequately financed so that we are capable of buying what we need in terms of pharmaceuticals and other services without incurring debt.
Yeah. Senator Mandago, you're in the very unique position. You were governor for 2 terms, and now you're senator. In your opinion, has devolving health to the counties worked?
Thank you very much, Jeff. But allow me to just make a comment on what Professor has just said on the issue of payment of debts to KEMSA. I don't quite agree with him because, you know, Jeff, county governments run on a budget. And for you to procure, you must have in your annual procurement plan and in the budget the amount you intend to spend. To me, from my experience as a governor, one of the reasons why counties don't pay on time sometimes is because KEMSA are unable to do their balancing because of the fill-in rate. For example, what the CS has just mentioned, if Vihiga County made an order of 20 million and they only supply 16 million, before they do the journal entries to make sure now they bill correctly 16 million so that we're able to pay, the purchase order was for 20 million. So sometimes it takes time. 2, the reason why some counties are unable to pay is because they overstate their own source of revenue, and therefore in the budget, it looks like they have sufficient money to do procurement, but yet in actual sense, there is already a deficit right from the budgeting process. Notwithstanding the fact that counties need to be more resourced, there is also need for counties themselves to put in mechanisms to make sure that they are not overstating their own source of revenue and therefore living in an illusion that, you know, they have adequate resources. But I think also KEMSA on their part must now improve on the system, and we are happy they are doing the IRP. In terms of whether health is working at counties, oh yes, Jeff, it is working. I would say 10 times, even if we are to rate counties, the 47 out of 47 county is doing much better in terms of health as opposed to when it was managed at the ministry. And the reason is very simple, Jeff. The supervision between the delivery of service at the level 1 facility to the office of the governor in terms of information processing on delays can take as short as 30 minutes or as short as a phone call of 30 seconds. And because of availability of governors, CC, the managers of health at the county, the members of county assembly at the grassroots level, feedback from public takes a shorter time, and therefore action can be taken. From when devolution started, you agree with me that the number of health workers who have been recruited are more than what used to be recruited at the ministry. That is not to say we don't have shortage of health workers. We still do have shortage of health workers. And one of the things I would say is we should stop bashing counties as expenditure centers in terms of personal emolument. Health, 90% of the cost of health is actually on human resource. For example, today, we aspire as an administration to roll out UHC. We can't do it without sufficient human resource on health. And that's why we still have to have another conversation separate from this on the aspect of human resource for health and costing.
I think I want to correct my friend Mandag on one issue. He was lucky when he was governor was in Gishu, because he was lucky because MTRH, we're teaching a referral hospital. It's a level 6 hospital, which is funded by the ministry. We have a level 6 hospital here, which up to now has not been, and I'm glad Susan said today that they're going to take over Jaramogi, a level 6 hospital, which we have had to fund. And it treats patients from all over the regions, come from Uganda or even Sudan. And so when we have a budget in health, which doesn't include Jaramogi, then I have to find out some money somewhere to finance Jaramogi, which cuts money from another expenditure line. So he didn't have that experience, so he doesn't know what's happening, unfortunately. But we have had discussion with Susan, and I think we're going to solve the problem.
And what did she say?
We are going to solve the problem.
So, Madam Sia, that brings me to what some critics say, that health should not be devolved. It should be dealt with by the national government.
No, that, no.
You know, the Constitution
we didn't say
is...
that.
No, it's not you. I said the critics, not you.
Okay, fine.
We work within the tenets of the law. As it is, there are those functions that are carried out by the county government, and there's what we do as the national government. And I want to agree with what Senator Mandago has said, that devolution, the essence was to take services closer to people. And one of the services that needs very close attention between the service provider and the recipient of the service is healthcare. So we have to collaborate and see how is it that then we work together, the national government doing its function and the county government, to ensure that we provide service to a patient who is a patient, not exactly a national patient and a county patient. All they need is a service. But having said that, and to go back to the issue of the debt, I think it's important for counties and for governors to prioritize the health of their people. If you prioritize healthcare, then the same energy and vigor that you put to pay a contractor who has done a road should be the same that you put to pay KEMSA after it has supplied. We have realized that there are gaps. So as a national government, we brought in a law, the FIF law, Facility Improvement Fund. What that law is meant to do is to ring-fence resources, that once a service is provided at a facility, then that facility replows back the resources that they have made from that service into the facility. Because previously you'd have instances where a service has been provided, a facility has done dialysis to a patient, they have collected money from dialysis, but they do not put back the money to buy reagents. Instead, that money goes to construct a road somewhere. So now we have a law, and we are working together with the county governments to have the guidelines to operationalize that law. And with the facility improvement, then it is expected that resources should be retained within facilities. But the bigger conversation that needs to happen, Jeff, is health financing in general. Health financing. How do we finance healthcare? And I'm happy Prof is here. He has been in the shoe that I'm in now. He will tell you that without proper financing for healthcare, HRH will always be an issue. Infrastructure will always be an issue. commodities will always be an issue. And I'm happy that at the national level, we now have the law on the social health insurance. And now we have even finalized the regulations. They are with the AG. I anticipate that by Friday, they will be gazetted, the regulation. And once they are gazetted, that starts the process of us having proper health financing to take care of all the issues that we have within healthcare. Yeah.
Does everyone agree on this panel?
Okay.
Do you agree with SHIF?
Sure. You know, when I was Minister of Medical Services, I found an institution which was called National Hospital Insurance Fund. So I said, you cannot be insuring sickness, you should insure health. So what we should have is a National Social Health Insurance Fund. And I'm glad it's now a reality. And in fact, we were the first to change the act governing NHIF to make a National Social Health Insurance institution. But the board was very resistant. We were a very conservative board. In fact, when I suggested that the way to do it is to have a graduated way of paying to the National Social Health Insurance, what I call from each according to his ability to each according to his need. Right. So that me, who was a minister, who was earning more money than my driver, I should not have been contributing 500 shillings to NHIF that my driver was contributing. I should have been contributing 2,500 shillings a month while he contributed 500. So that I have more ability to pay than him, but both of us have needs. So when we put this money in one pot, then the needs of everybody is met. Those who have and do have less. When I said that, somebody, I won't mention the name, because I went on TV and said, look, I can afford to go to Serena and spend 2,500 shillings on a lunch. My driver can't. So rather than spend that 2,500 shillings on lunch, let me pay to NHIF. And somebody very important to us said that the minister is bragging to us that he goes to Serena to have lunch. I was just giving an example. But you know, the thing was bashed so much those days that we never succeeded.
So Prof should thank me now.
Yeah, I mean,
that what he wasn't able to do then, we have done it now.
I agree with you.
But tell me, okay, if it's gazetted next week, it kicks in when? Did you say June, July? Or?
And I need to correct that. That we gazette, hopefully on Friday, the regulations. Once they are gazetted, they come into effect. So that means then deductions begin end of the month, end of March.
And this is 2.75%?
2.75% of income. What Prof had desired that it should have been done then, that is what we are going to do now. However, in terms of access to services, because we need to register people, we need to collect the contributions, then now prepare to provide the service. So our projection is that from this month of March, we need about 3 months to prepare ourselves, because we need a system, a digital system to do registration. We need to test it and then collect resources. But effective the new financial year, which is July, now Kenyans can begin to access services under the Social Health Authority.
How does that benefit you, Chairman?
I think from KEMSA, it's really about the commodities. For us, we'll be able to get the payments directly for the commodities. And then we'll be able, as we get because as we had, currently our biggest challenge is funding. So the reason why we have 70% order fill rate is because we do not have the money to buy all the products. So what this will be able to do is actually provide us all the funds that we require to be able to provide the commodities.
The other thing that KEMSA was known for, and forgive me for rehashing the past, you weren't part of it, but you know, it happened. The tendering process. Yeah. Remember that story that someone was walking out the outside the premises, and they were called in and they were given a tender?
Yes.
Right. I mean, it was that bad a reputation. Is that changing?
That has changed. Actually, that's changing. That was during the COVID. And as you remember, there were challenges of procurement during COVID because the law does not even have any provisions of how to procure during a crisis. So if by the time you do a tender, and then you put in the newspaper, someone is asking, why are there any PPE? So I think that's probably what happened at that time. But for us, what we've done is actually we try to change as much the face of procurement. We currently even have already advertised for the director of procurement, so we'll be bringing in a new person. We've reshuffled the people who are in procurement, quite a number of people, we've moved them out. There are some who we haven't yet, but we'll do that. We've come up with policies. One of the policies, we've come up over this period with about 35 different policies, but some are on procurement. One of them is on whistleblowers, that allows the people within the organization to whistleblow on issues around procurement. Then, as I mentioned, is the issue of the system and the ERP, because what we had is actually just tracing and tracking, and the accountability were not being captured. And that's, again, one of the things that we are changing within that. Finally, when we came in as a board, we cancelled all the tenders that were ongoing, and we started them afresh. And by doing that, we also reduced the sizes of the tenders. So where they used to have a tender of 1 billion shillings, we created, even if it's 3 lots of 300 million shilling tenders, so that thinking of somebody is coming for a huge tender from KEMSA, that can go away. So that now we have more Kenyans supplying to KEMSA, and the interest, reducing the interest. And that has really helped us in managing the tendering process. We did our last tender, which closed in December, 5.4 billion, about over 200 different items, and we finished that without a single person going to PPRA to report that the tendering process did not work. So that, to us, we consider that to have been a very successful tendering process.
So that reputation of you guys being a cash cow, that reputation of KEMSA being a cash cow, that's going away. Yeah. That's going away. So what we are saying is there's business. You see, at the end of the day, the tendering, people come for business, but it has to be done right. Yeah, the right people have to be given the business for the right prices, following the right procedures and processes. The issues of interference are the ones that we said we don't want interferences, because interferences leads to the wrong prices, leads to the wrong products, and of course, at the end of the day, issues of integrity and ethics. Absolutely.
Yeah.
Dr. Pukosi, let's come back to SHIF. In your opinion, is it a game changer?
Thank you, Chief. To me, I think it's a game changer. One, I wanted first to comment on something that Prof said about hospitals that are initially, like Jaramogi Oginga Odinga, which were initially serving bigger areas. I remember in the 11th Parliament, that is 2013 to 2017, there was what we call conditional grant to such facilities. But apparently that conditional grant was abused, because that conditional grant was meant to benefit hospitals that were serving beyond that county, the former provincial hospitals. But you realize that that was abused, and the money now that was meant for conditional grant was now distributed all over to all the counties. And I think that has not achieved what it was meant to achieve, because you find that now Jaramogi Oginga Odinga and many others, Garissa Hospital and others, have ended up suffering because they are serving people beyond those counties, and therefore it constrains the resources for counties. When coming back to SHIF, SHIF has, this has 3 elements. You have care for the primary health care, which is going to through the primary fund. Then you have emergency, chronic, and critical illnesses fund. And then you have the fund for the social health insurance fund that will take care of people as anybody sick, right from level 4, level 5, level 6. Initially, many of the people would sell their land because people are suffering from chronic illnesses, diabetes, hypertension, kidney diseases, renal dialysis, And therefore, once you exhaust your cover for the NHIF, then you are left out that way. When you look at the NHIF cover again for even kidney patients, it does not take care of post-transplant cases. And therefore, it subjected people to still remain only on renal dialysis. Unlike now, where you have this new scheme, which will take care of, should somebody opt for renal transplant, then you will have post-transplant renal care. And that will be able to make these people to go back to their normal day-to-day activities instead of somebody traveling twice per week to the hospital for renal dialysis. So to me, I look at it as a game changer. Right now, if you have emergencies, let's say people are involved in a road accident, how do you take care of, who takes care of that bill? Because you don't have an emergency, fund. And even as it is today, NHIF is supposed to have an emergency cover. But how many people know that NHIF is supposed to provide you with an ambulance? It's very few.
Right.
Yeah? You'll find that when somebody has an emergency, you'll have to look for maybe the county or look for your own means to be taken there. Yet your cover, which is supposed to be NHIF for emergency, is never utilized because people are not ignorant about it. It's just been kept maybe for a few people to benefit from it. And therefore, I think to me, with the SHIF and moving into more transparent way, then Kenyans will be able to access more care and more benefits. But my appeal again would be to our public hospitals. They must also provide good care so that somebody will feel comfortable going to a nearest hospital, whether it's public or private. Because as it is today, the biggest beneficiaries from NHIF are private hospitals. Public hospitals, their bills are very minimal because the kind of service they are offering is not up to the level to compete with the public hospitals. So I think it's a challenge now to our public institutions that you should be able to provide good service, provide quality service, because in this country, almost all the best doctors, they're in public hospitals, but working in private facilities.
Jeff, there are two issues I'd like to amplify on what the chair has said. One is the benefit package within the Social Health Authority. We have attached the package to the regulations, so once we publish, Kenyans will be able to see it. But just to highlight is that this package is taking care from the beginning of life to the end of life. That this package takes care of an expectant mother. It will take care of the clinics that they do, take care of delivery, take care of the child, immunization, and as they go through development to adulthood. And in fact, it also has a benefit for last expense, because as it is now, NHIF does not provide last expense. But under these new regulations, one of the items in the package is last expense. The package is very expanded. Previously, NHIF and even some other private insurance, they would never cover congenital diseases, but we have taken care of them in this package. The chair has highlighted, previously a patient would need a transplant for a kidney. NHIF would not care for the preparation for the transplant. It doesn't take care of that. It only takes care of the transplant, and it doesn't take care of the medication that you need after. In the current laws, we are taking care of taking care of the transplant itself, and taking care of the medication that is required to ensure that then the kidney is it works with it in the new patient that has been transplanted to. The other issue that I need to highlight from what the chair has talked about is the issue of emergencies. That previously, when somebody or people are involved in a road accident, you'd have people who come as first responders, but they would be shy away from taking this person to a facility because they immediately put that person in their vehicle, the patient becomes their responsibility. So under the new laws, we have now provided for the fund that once you are involved in such an emergency, the fund takes care of you. So Kenyans who find themselves in a scenario where they are the first responders should no longer feel shy of picking up somebody who has been involved in an accident, because they will, that patient is covered through the emergency fund. Yeah.
Okay. Madam CS, Governor, Senator, Chairmen, we're going to take a quick break, come back and talk some more, because this is very interesting. That you're highlighting things that we didn't know about, even though that 2.75 is going to be very painful.
Jeff?
Do you agree, 2.75? Yeah. You like it or you don't like it?
You see?
There you have it. Okay. All right, we'll talk some more. We'll come back. We'll get questions and comments from the floor as well as we continue this conversation live from the KEMSA RDC here in Kisumu Town, Kisumu County. Jeff Koinange Live is on the road. We're having a very robust conversation on the state of health and KEMSA's role in this country. Jeff Koinange Live takes a break. Keep tweeting at Koinange Jeff, at Citizen TV Kenya. The hashtag is JKLIVE. JKLIVE takes a break. We'll be back in a moment.